USMLE style question. A 42-year-old woman presents to the clinic with morning stiffness lasting more than 1 hour and pain in her wrists, hands, and knees for the past several months. She reports worsening joint swelling and fatigue. Physical examination reveals bilateral swelling and tenderness of the metacarpophalangeal, MCP, and proximal interphalangeal, PIP joints, with ulnar deviation and joint subluxation. Laboratory tests show a positive rheumatoid factor, RF, and anticyclic citrullonated peptide, anti-CCP antibodies. Which of the following best describes the underlying pathophysiology of this patient's condition? A. Autoimmune inflammation due to HLA-DR4 causing pannus formation, which erodes articular cartilage and bone. B. Immune complex deposition leading to complement activation and neutrophilic infiltration in the joints. C. Increased chondrocyte degradation due to mechanical wear and tear. D. Monosodium urate crystal deposition in the synovium, triggering neutrophilic inflammation. E. T-cell mediated destruction of exocrine glands, leading to secondary joint inflammation. Answer. Autoimmune inflammation due to HLA-DR4 causing pannus formation, which erodes articular cartilage and bone. Explanation. This patient has rheumatoid arthritis RA, a chronic autoimmune disease associated with HLA-DR4, leading to pannus formation, granulation tissue with fibroblasts and inflammatory cells, that invades and destroys articular cartilage and bone. It is a type 3 hypersensitivity reaction involving immune complex deposition, as well as a type 4 hypersensitivity component involving T-cell mediated inflammation. Key features of RA. Autoimmunity, associated with HLA-DR4 and anti-CCP antibodies, more specific than RF. Joint symptoms, symmetric involvement of small joints, MCP, PIP wrists, morning stiffness, type 1 hour, joint deformities, ulnar deviation, Swan-neck, Boutonnière. Extra-articular features, rheumatoid nodules, interstitial lung disease, vasculitis, anemia of chronic disease. Radiographic findings, joint space narrowing, bone erosions, periarticular osteopenia. Treatment DMARDs, e.g. methotrexate, TNF inhibitors, NSAIDs, glucocorticoids for acute flares. Incorrect choice is B, immune complex deposition leading to complement activation. Describes systemic lupus erythematosus, SLE, which can cause polyarthritis but lacks joint erosions. C. Increased chondrocyte degradation due to mechanical wear and tear. Describes osteoarthritis, OA, asymmetric, worsens with use, osteophytes. D. Monosodium urate crystal deposition, gout, which presents with episodic monoarthritis, first MTP joint most common. E. T-cell mediated destruction of exocrine glands, Sjogren syndrome, which causes dry eyes and dry mouth with secondary arthritis. Would you like a follow-up question on RH?